I think majority of the clinicians involved in the treatment. And my role ends here. The agendas for the panel discussion are generating an organized referral system, grassroots level networking, mapping of services. Like I was talking to Ritu ma'am, if anyone asks me to tell me 5 good speech therapists in Delhi, I will not be able to name who are involved in Cleft, right? And registry of congenital anomalies, which we all have been talking about, and many of us were not aware of the Rashtriya Bal Swasthya Karyakram and the NEEV program. The lead of NEEV program will join us shortly. Early Evaluation Vision, which is the Delhi government program. And in both these programs, the registries were started. The first RBSK program was funded by WHO, and which ended in 2022. And NEEV program is currently running and perhaps has started from 2023. So I think we can start the panel discussion because we don't know each other. We can have a quick round of introduction, and then we will work on these agendas. So we start from
plastic surgeon, Chennai.
Batra, orthodontist from Delhi. Yeah, hi everyone. I am Krishnamurthy. I am not a doctor. I am a social worker. I am from Jamia and also did some practice in the UK. So I am based out of there.
And you are the country head of?
Restless Development. There's an organization that works on sexual and reproductive health rights. So we work with a lot of first-time parents, particularly telling them about similar things that could happen to them, how do they prepare, how do they work with their own ecosystem, support system. We do that work.
Mr. Nawal, can you add on anything else? Why this agenda is very close to your heart?
Sure. Frankly, I myself a parent to a child who was born with cleft lip and palate. So we became parents for the first time 10 years ago, and unfortunately none of the different tests could alert us about this thing that was coming to us. Being a social worker also, we were really surprised, though I used to work with other parents. We were in counseling services and psychosocial support that we used to extend, but we ourselves were really surprised in terms of how that impacts you as an individual, and particularly how that impacts your relationships around you, not just you as an individual. So keeping child centrality, that time was so difficult because there was not really a lot of services. Since our child was born with cleft palate and lip, we were looking for service providers who could provide special feeder bottles or other equipment that was required, and we were not able to find them across Delhi. So I'm being from Delhi, raised here, knew a lot of people, still we could not find a lot of services then. So I can really understand the importance of the agenda. If we have a repository of service providers, and we struggled to get speech therapists, we were lucky enough because of contact with the people we knew. We met Dr. Who kindly helped us initially. Then Dr. Batra here, we have been seeing him for the past 7 years now. So we were lucky because of contacts we were able to gather these people who became our allies in this service towards the child. However, I can feel for the parents who are not in Delhi, who are outside Delhi, who are in rural areas. We work in Odisha, we work in Jharkhand, we work in Bihar, and there is literally not enough services. I am sure all of you are practitioners here, clinicians here, but the social side of it is so important and so vast that we have to take care of both sides, from medical side as well as the social side of the issue. I heard from Dr. Badri that a child, once he or she completes first 18 years to 20 years, they are about to announce themselves to the world. But from my lens, from what we saw with our child and also children across that we work with, that child is already in the world. They are already in school, they are already talking to their peers, they are already talking to different networks that they have. So they have already announced, they have already arrived, the children are already there. So how do we build support system so that child goes through that support, which we have not yet found a good child psychologist, for example, who could work on this particular issue and support the child in his growth. Because child herself goes through so much through this process. There are lots of questions, I'm sure all of you might have seen it, might have experienced it, but seeing that within the household firsthand was something way different than how would I have seen if it was not my child who was undergoing this. Maybe more and have a chance.
Thank you
to
so
see.
much.
I would like to respond to it, but once the introductions are on at some point, maybe we should have a little chat on that.
Sure.
What you brought up is pretty important.
Hi, myself Dr. Subodh Singh. I'm working in a comprehensive cleft care center at Amandeep Hospital with my project director, Dr. Jamia Millia in Amritsar, Punjab.
Good afternoon, everyone. I'm Dr. Badri, an orthodontist from ESI Dental College Hospital, Delhi.
Hello everyone. I'm Dr.Seema Kapoor. I'm professor and pediatrics specialist working in
I have practiced in UK and at the moment I have a center of fetal maternal care. So I'm basically a fetal medicine and also do maternal high-risk cases.
This is Dr. Ashish Jain. I am Associate Professor in Neonatology at Maulana Azad Medical College.
Ashish sir, can we have you here please? Because we'll be needing lot of inputs from you.
The
Please.
chair is very
No,
luminous.
you come here. You come here, sir. Please.
I'm Dr. Sangeeta Gupta from Maulana Azad Medical College and I established the fetal medicine services. We were the first institute, public sector, to have fetal medicine services in Delhi after All India Institute of Medical Sciences.
Hello everyone, I am C.D. Thomas, speech therapist, working on the Child Development Center, Maulana Azad Medical College.
Good morning everyone, I am Dr. Arpita, I am Associate Professor of Pediatrics at Maulana Azad Medical College and I am trained in development and behavioral pediatrics. And right now I am in Child Development Center and working as a specialist in Center of Excellence at Early Intervention Center under RBSC also.
Dr. Singh. I have my ultrasound clinic in east of Kailash and I deal basically more with fetal anomalies and anomaly scanning and TFA scanning. That is going to be dealing with what the problems we're going to be discussing today.
In India and abroad. In 2015, I founded an organization in India called AIIMS, which has contributed as a small way to the cleft work in the country. Thank you.
Hello, I'm Dr. Sanjeev Kumar. I'm a maxillofacial surgeon. Presently, I'm the project director of Smile Pain Center at SGT University, Gurgaon.
I'm Chetna Khandelwal. I'm working in San Parliament Hospital, which is in Civil Lines, Delhi, and my plastic surgeon is Dr. Sood. I'm working in Smile Trail from last 5 years.
I'm Krishnamurthy Bonanthaya. I'm a maxillofacial surgeon. I've been working with an organization called Smile Pain for the last 2 decades. Currently, I'm also chairing the Indian Medical Advisory Council.
Good afternoon, everybody. I'm Dr.Ghosla Reddy. I'm from Hyderabad, from the Smile Trail Center, GSR Hospital.
I'm a plastic surgeon from GS Memorial Plastic Surgery Hospital, Varanasi, and we have a comprehensive cleft care center, and is a Smile Trail partner as well from since 2004.
I head the Department of Maxillofacial Surgery at Sharda School of Dental Sciences, and I also run a practice exclusive to maxillofacial surgery for the last 6 years in Mumbai.
Hello. Good morning everyone. Myself Dr. Kamlesh. I am working at a comprehensive cleft care center, Smile Train project, Vivekanand Polyclinic and Research Institute, Lucknow, and my project director is Dr. Anup.
Good morning everybody, I am Dr. Ritu Duggal. I am an orthodontist. Right now I can just share with you that we have been giving comprehensive cleft care in AIIMS dental department since its inception. That time we were just a department. Once we converted into a center, the discipline of orthodontics has been doing this in collaboration with other disciplines of AIIMS. We are also running a fellowship program in cleft care, and I would love to be part of this. I have few suggestions which during the course I will be giving my thoughts on.
Good afternoon everyone. I am Dr. Deepak Nanda, Professor of Plastic Surgery at Safdarjung Hospital.
He's also the co-PI of our project.
Good afternoon, everybody. I'm Dr. Anup Kanase. I'm professor of orthodontics at Maulana Azad, and Professor Ritu Duggal missed out on saying that she heads the Resource Center for the National Oral Health of Government of India, and I head the program in Delhi. I'm also the director for the Dental Cell for Delhi Government and elected Dental Council. So I'm here on Panchali's request that we can have this multi-center involvement and so mapping, which is part of my profile as director for the Dental Cell in Delhi Government, in increasing the centers and having collaborations. Another important aspect is that the National Oral Health has huge funds, and maybe we could also contribute in that aspect because AIIMS has a National Resource Center and other opportunities are opening up.
Anybody talk about giving funds?
Yes,
Anybody saying we have funds?
Yes, we have huge funds. Thank you so much for this opportunity.
I would request Dr. Ashish to please brief us about the registries, about the RBSK and about the NEEV program. We'll be having Dr. Seema Kapoor joining us shortly, who is the lead principal investigator of the NEEV program. So can you please brief us about these registries?
Basically, the first registry which came was the registry by the WHO, sponsored by WHO. And it came in for the Delhi hospitals, which was called as the NBBD, that is New Delhi Birth Defect Registry. So that started somewhere in 2015, and it was initially started with maybe 4 or 5 hospitals. Then quickly it was upgraded to around 19 hospitals. So they had a dashboard, software and a dashboard on which these hospitals used to upload the birth defect. It was a simple form telling the description, the ICD code of the defect, basically the visible birth defects. And the AIIMS Genetic Center was actually doing the surveillance audit about the quality of the uploads, the description and the designation of the birth defect. Unfortunately, this registry stopped in November 2022, and as it stopped, there were the data operators, the data upload people who were given to these hospitals. So as of my knowledge now, none of these hospitals are actually uploading the birth defects into the dashboard, even though the dashboard is alive, and you can still upload if you want. But for obvious reasons, as they're not getting any funds, they're not getting anyone to operate the data, so it's not been done. The other thing was the RBSK. The RBSK has its own system of getting the birth defects. So that is mainly through the district hospitals and the SNCUs. The SNCUs are the sick newborn care units. So you must have all seen that they have mushroomed over the past 5 years. To start with, they were around 60, and now all over the country there are nearly 600 of them. So they have another dashboard of themselves, and that dashboard is now being even used by the Delhi Directorate also. So that has just one column telling about the birth defect. So that is how the RBSK gets the birth defect information. And the NEEV project has started just last year. I think Dr. Seema will rest about it. So they have their own way of connecting the visible birth defects. So that is how these registries were there. And then we have different hospitals, which are tertiary hospitals, who have generated their own system of gathering the data. Like our hospital, we have our own system. So we keep the data of the birth defects, which is there. So that's how it is there. But there is no uniform registry where everyone is linked into. The WHO surveillance program was a very ambitious one, but then they could not support it beyond 2022. So that's the current status of registries, at least in India, as of I know.
We know that the diagnosis happens much before. We want to hear from Dr. Kuldeep and also Ma'am Kaini HB Ma'am. Is there some systems where we report prenatal anomalies to the government? Is there a system? Do we follow a system?
Not so far.
So then even when you register the birth, there is no system to record a congenital defect?
No, we don't have any so far.
Was it the DNA?
form, we do write if there is any malformation seen. There is a column where we write what is the problem. It's get registered because I don't know whether it gets registered or where it goes, but we do fill a form, and now all the forms are also filled online. So not just the physical form, but the online form as well. Somewhere the data is going, whether it's getting collated or not.
So, but there is no onus on the hospital or the doctor to definitely report something. That you're not. There is no.
In fact, the first birth defect registry was the one we had worked in collation with, the one described by Dr. Ashish. Yes.
So, what about?
The thing is, it's just the reporting and the follow-up. That's all individual. In terms of having a club all together, that okay, all the anomalies are going to be really reported here, so that we all can have a follow-up. No, there's nothing as of now. We were planning an anomaly registry that's not only for the cleft but for everything.
Exactly.
So that then we know, okay, there's how much of a percentage we will be always and always rely on the data from the West. And there are a huge number of anomalies that we're diagnosing now because of the upgradation of all the machines. So we definitely need to have a registry.
So when we have these clinics where ultrasound is happening, so it's only the reporting to the patient that's happening and never a reporting
No,
to...
See, that's what exactly ma'am said was, we have a PNDT where in the terms of what exactly was the diagnosis, we're going to be reporting that. But what is going to happen with that, in the PNDT, they're just interested in, okay, you've done an ultrasound, this is the address of the patient, previous children, this was the sex, and the further details about the referral slip and what would be
But what is being done with that data?
in terms of, they have a complete different set. The prenatal diagnostic techniques, pre-gestational sort of a thing,
So
they have
where
a
is that
different
data?
approach.
Where is
See,
that
the
data?
objective of collecting the data is very different. It is to ensure that no prenatal sex determination is done, and we are giving an undertaking. So it is more from the law and act perspective than from medical perspective.
So if you encounter, if you identify that a patient or baby has a cleft lip, that might be difficult. Do you refer the baby to someone for aftercare or psychological help, or does that happen?
Of course, we have a system in place which is not very well organized being a public sector. But of course, any anomaly we identify, we always take a multidisciplinary approach and we take the appropriate reference right from the time of detection.
Okay, let's say they ask me a question, Dr. Kuldeep, what do you feel, what has to be done? Okay, this, what are the other things that we need to be asking for in terms of the other biochemical tests or any invasive tests, which I think so we're going to be discussing in a little while. So once that has been done, then the obstetrician is going to be taken care with the plastic surgeon, with the dental surgeon, with all that team. Okay, now when the baby comes out, all this has to be done. But then I get a follow-up only when the baby is born or in the next coming few ultrasounds. And after that, whenever the parents have the other baby, then I figure out, okay, this is what the answer.
But I think that we should be talking about the antenatal detection and a good surveillance there. Only if there is some intervention you have to do antenatally. Otherwise, we should, if we are thinking of counting babies appropriately, not missing anyone, I think the neonatologist is the best person because as such in the intrauterine life, you are not going to do anything. So if you strengthen the surveillance at birth by pediatrician or neonatologist, that will be giving more dividends. So when we are thinking of counting, we should actually see that where maximum we can pick up and then the minimum.
Krishnamurthy sir, different Krishnamurthy sir.
Coming to the issue of intervention after antenatal diagnosis, there is a role for intervention. Most important thing is for somebody in the cleft care team to talk to them, counsel them and prepare them. It's a phenomenally important thing that we need to do, sir, because what tends to, there is two sides to this argument. Should they be told? Will it not be a shock? But that is going to happen in a few weeks or months. So most of the times we have an informal setup where I come from Bangalore and some of the fetal medicine specialists send them to us when there is a diagnosis, and invariably we find that the time that we spend with the parents is very useful. The first thing that they want to know is whether they want to continue with the pregnancy. It's a massive question. And that is something we try to answer without being judgmental. And once they decide to continue with the pregnancy, there is a support so that we come into play as soon as the baby is born. I think it's very important there is an intervention.
Yeah, and secondly, I just want to make a comment as a fetal medicine specialist that these babies need a further detailed evaluation, whether they would require something like an amniocentesis, and their reproductive options like termination of pregnancy should be open to them in the stipulated period. So from that perspective, and with the skills of the ultrasonologist in today's era and with the advanced kind of equipment we have available, the diagnosis has been pushed to as early as before 13 or 14 weeks. So there is definitely.
Is it legally allowed to abort a patient with cleft lip in India?
See, yes, till 20 weeks actually, if it is not a severe malformation. From 20 to 24 weeks, we only allow termination for a severe malformation and then associated chromosomal abnormalities and so forth. And I think when you talk of termination to any patient, that's the time when what Dr. Murthy just said, that how well they are, concerned by how well they will get a support after delivery is very critical in decision making for the parents.
Can I add on a little bit in that also? Exactly what ma'am said. The other thing I feel as an ultrasonologist, radiologist, fetal medicine specialist, anybody who's doing an ultrasound, rather than the parents getting a shock later, we should not be shocked at seeing, because the patient can see it on our face. So the moment we see a cleft, we should not be alarmed, because the moment we are alarmed, the patient thinks only of one thing. They do not think of any other thing, they feel that it should be terminated. We need to be, first person to be counseling is the person who is doing an ultrasound there and then, showing them on a 2D, showing them on a 3D, 4D, and we have these reverse 3D facilities, we have a glass fluorescence imaging, all that is fair. But once you can show them that, okay, it is only this much or a little bit more, and then we're going to do further tests. That the moment the diagnosis is made, counseling is extremely important, because that is going to calm the patient rather than just going haywire about it.
But what I understand is that majority of the tertiary centers, and I'm talking about Delhi, are not well equipped with 4D diagnosis. They have the conventional 2D diagnosis. So is it possible for them to detect the cleft?
Even on a 2D, one can fairly make a diagnosis of at least a cleft lip. Then you need to be looking at the alveolar ridge. Then you need to be looking at the uvula, where are you able to see the equal to sign. That is all on 2D. Just to make it a little more presentable to the patient and the plastic surgeon, we require a 3D, 4D. I'll be very honest, there's never been a diagnosis where I missed out on a 2D and I figured it out on a 3D, 4D. It's just to accentuate that image. I show them on a 2D, there is a cut, they will never realize it. On a 3D, they can face, okay, this is what the thing is.
Well, I would like to add here, coming from a public hospital, that sir would of course be diagnosing, but we are getting quite a few undiagnosed cases in the late, second trimester, early third, and
that is what I'm saying, it's actually low.
And the kind of scans that we are seeing are not really very good quality scans. So that part is also there, that the detection rate is actually now would also mean that the detection.
I was talking to Dr. Anju from Maulana Azad, and ma'am said that cleft is least of our priority, with 40 ANCs doing per day. So we hardly, and maybe in the private sector the scene is different, but a low socioeconomic patient who is walking into a tertiary care center like Maulana Azad or Safdarjung, so I don't think that these cases are diagnosed at that point.
See, there is a lot of heterogeneity in the equipment used, in the skill of the providers, in the workload. So there is no way to have a uniform care for all, and it's not just in cleft. I think it's in every segment of healthcare system. So we have that challenge, and we have to acknowledge that challenge, and we have to find ways in our own system to overcome, and how far we can overcome them, and we have to set our priorities also.
What is the mean time of detection, like gestation of detection, if the mother is
If a fairly,
just in a gray zone of termination?
if a fairly nominal good quality scan is performed, I think the anomaly scan time is between
20 weeks
around
is
20
fair.
weeks is getting it in the first trimester is going to means to have a very skilled operator and have a very good machine.
If you have a median cleft, that you'll be able to figure out when you're looking at the retronasal triangle, even in the first trimester, in the NT scan, you'll be able to figure that out. Otherwise, routinely a cleft lip with that modified coronal plane to see from here, you'll be able to figure out on a 2D a cleft lip or not. How severe and all that might be, they can always refer. And man said the correct thing is, it depends on workload. I do an anomaly scan in 40 to 45 minutes, and in places where there are 100 cases a day has to be done in 40 to 45 minutes, they would be finishing 5 or 6 cases. So that is always and always there. Depends on the baby's position. If I have not seen the face, I'm going to wait, tell the patient, go, have something and come back. In patients where there are hundreds of patients waiting outside, you cannot have all this.
Well, continuing on what once the baby is diagnosed, of course you need to rule out everything, and the choice is till 20 weeks, it's the parent's choice. Most of them in our experience decide to keep the pregnant. And we have a system in place, I'm sure all of you have, I mean some of my colleagues have that in place. We have a feeding nurse who, when the parents come to us either prenatally or postnatally, after birth, we have, after we speak to them, we have a feeding nurse who actually counsels them at great length. She also, even prenatally, what to expect, and some of these children have difficulty in sucking, obviously. So she tells them how to look after them. She has they have her phone number. Sometimes they call her in the middle of the night. She handles nearly about 1,000, 2,000 patients at any given time. Probably we need to have more like that. But at the moment it works well. So none of our patients are lost when they, like what he mentioned. I'm also talking about the free non-paying patients who are supported by Smile Train. We have, they also have the number of the nurse. Obviously, they can't be calling all doctors and things, it sometimes becomes, but the nurse has the number. And whenever they say, and we have a nutritionist as well. I think Smile Train has implemented that program at other centers as well. So there is a lot of support, only if you know where to tap.
So far in my practice for a non-syndromic cleft, we have also never did a pregnancy in the public sector. Because we do take care that we ensure that there is no other associated problem, and then we try to give as much support as we have in our sector. And not to my knowledge, isolated cleft is not.
I have a quick question on this. It's, as I understand it, it's the patient, that's what we tell them, it's the patient's choice. Until 20 weeks, if they wish to terminate the pregnancy, they can. They don't need to give a reason. Is that accurate?
The new abortion law in India.
Yes. 24 till 20, Sangeeta ma'am, that is not applicable to cleft.
I don't want to go into that chapter. That's a totally different and elaborate chapter. But if you read the MHRD law very carefully, till 20 weeks the patient can make a choice even if it is a non-lethal, non-severe malformation. Beyond 20 weeks there is very clearly defined indication in which the patient choice or failure of contraception or a minor malformation doesn't fit. So I think people will get more clarity as in when we start going into the details, but because I'm a member of the MHRD board also, I have gone very thoroughly through it, and this is a message which I try to give in every forum. In 20 to 24 weeks, we should be very careful in prescribing MTPs, because true clinicians have to give their consent.
So I would like to add 2 points here. One is that we do have patients coming in when the baby is being diagnosed with a cleft. So there were 2 couples where in one case the father and in another case the mother had undergone surgery for cleft. So they were like, we've had multiple surgeries. So that counseling part, that what they are feeling. If they've had a difficult time, then they don't want that thing to happen with the child. It could be otherwise also. There might be other couples, I don't know, who would say that we are fine. So the child with a cleft, we are good with that also. So that is one point. The other point is that they sometimes ask us that if it is a girl child, which obviously nobody can disclose, then we don't want, because a girl child with scars and also that counseling again, becomes a bit difficult.
This is very difficult to, if it's a constraint like this.
So that's what I'm saying. These are the concerns where the couples come. So I wanted to share that.
We just finished a qualitative research project interviewing parents, caretakers of cleft lip and palate babies. We did quite a good cohort, and 95% of them wished that they were diagnosed prenatally and counseled at birth. That was one consistent information that we gathered from the qualitative study. I think we should have some kind of registry which would initiate or at least make sure that during the tick box exercise we pick up the diagnosis and get them referred. Perhaps your center, you guys are doing really well. There are lots of other centers who are not doing well. They should have a system in place to diagnose. I know it's very difficult in India, but if there is anything that we could do to change the system, even 1% change would make a big difference for the entire global Indian population.
Taking off from there, can I quickly ask a question about what has already been talked about? Sir, Dr. Ashish, this couple of questions for you regarding the facilities that you already mentioned. This RBSK dashboard, is this specific for Delhi or it's a universal Indian thing?
It's in the whole India, and it was developed for the sick newborn care units. So that dashboard has...
So only when they get referred there, their diagnosis is done.
These sick newborn care units, they have a data operator who has been provided by the ministry, and that data operator, he fills up the data, and the ministry monitors that particular.
No, but
data.
how do the patients get there? Only when they've had a problem, right?
Only
Not all the births are.
Only the patients who got admitted in essence.
Only those are the.
So it's a hospital, primarily a hospital-based database.
Can I have a clarification? UP we get patients on this RBSK team screens all Anganwadi children as well as primary school children. So they go to the school, they go to
That is not going online, no, Subodh. That information is not going online.
That I'm not sure about. They definitely bring those.
Yeah, they are diagnosing it or picking in referring.
Because they have a list of 36
Yeah,
different
so
anomalies.
what he's talking about is the developmental intervention centers. So RBSK is actually going through visible birth defects. Their management, I think it took 5 years or so. So the development intervention centers, they have the children coming even after birth from the community. So might be that the data of the cleft palate in these community goes to that database. But what I am talking is about the neonatal database. So the neonatal database is basically all the states have adopted, and these essentials they load for the patients they are admitted there.
Can I have one more question, please?
Yes, sir. Yes.
The WHO software that you spoke about, which you said we can still use it, who has a copyright or who owns it? How can someone get hold of it?
And can we revive it? That's what you want. Can we revive it and tell
Yes.
That's what you mean.
As far as I know, it's still active because all of us who were into it, they told us that you can still upload into that particular database.
So it's your team that's running it?
No. It is the subdivision's team. Dr. Shobna was supposed to be here. She was landing from Chile yesterday, but her flight has got delayed.
Yeah, so actually the subdivision team was coordinating, but the data is handled by the WHO country office. So the WHO country office has the rights for the designation for if you want to access the data. It will not be the subsurgeon but the WHO country office.
Not for accessing. If I want to start building up my own database using that software in my workplace or in my state,
I think the WHO country office, because they developed it, not the subsurgeon.
And unfortunately, in the latest WHO oral health guidelines, there is no place for cleft. I can't believe it. It was there last time, but this time they have. So WHO might not help us in prioritizing our needs.
But sir, if you search RBSK, they have a very good referral system, the forms that they have made. And it is, I think, the code 37, which is for the cleft.
So now the RBSK is to be, it's a country program, national program, which has to be adopted by different states.
And
so the states have to generate a mechanism how to use the benefits of RBSK. For example, quote unquote, the Delhi state has yet not generated that mechanism.
Exactly.
To whatever obvious reason.
Delhi has to come.
We have it for the genetic. What Seema is doing is for the genetic.
No, that's a project.
Yeah,
project mode.
This is the project mode.
Can I just add Dr. Ashish? But see, the RBSK program only records data when it's brought in by these Anganwadi workers or from the data from primary healthcare centers. The data at private hospitals is not recorded at all. So what happens because fortunately or unfortunately in India, cleft care is largely supported by NGOs and government programs. 90% or 85%. But what happens to the other 15% who go unnoticed, or maybe even 20%? We keep saying 10%.
So that's the construct of the data. The RPSK, you have to come to that facility. So it's a facility-based data. You have to come to that facility. Either in the neonatal period you have to get admitted, or beyond neonatal period during the surveillance, that person has to come with a problem. And those people are referred to the development intervention centers by different district hospitals, community centers. So maybe if they are doing a very good surveillance into community through their Anganwadi and that particular network, you may pick up the cases from the community, but eventually that is a problem.
Can I just make a comment on that? I think this RBSK, like you said, works differently. Like Subodh said, in Tamil Nadu, it works where the village health nurse. Every village health, there is one village health network. The system works very well in Tamil Nadu.
There is that way.
Yeah, there's a village health nurse for every 5,000 population.
Is this the same as Asha worker?
I don't know.
They have different names in different states.
They're called
Asha workers.
So it's Asha in other states. It's called different.
So I'll give you an impetus of this. How the national health funding, let's go only to forum or any health funding, is that the center provides you 60% of the money, 40% comes from your state governments. Be it any program, be it national board health, be it rabies, blindness, even genetic, which Seema ma'am will so right. So we have 60% money. Now the cap of the money is limitless because every state has to present the BIP to the center, and that is approved by all these meetings are held at Bangalore by the Ministry of Health. There is an additional secretary for health who heads this for all the programs. So our budget, depending upon the state program officer, budget program is good. Now, as we can see, the problem here is of how we get all these programs to integrate, and there is no stopping any private sectors to be collaborating with the state programs, because state program is open to everybody, and at state level now we are working at the tertiary hospitals, the district hospital, and below that in Delhi we have a system of Mohalla clinics, very soon we will have Naamapri dental clinics also on the same lines. They are either at the DGD, that is Delhi Government Dispensary, or Palate-Panel. This is the basic structure of the program for healthcare. Right? And apart from that, we have centers of excellence which are being built specifically for oral health. We already have 3 identified centers and 3 more have been approved in the last program. Maybe ma'am can throw more light on it as to how we're going to have national resource centers for different aspects. Right now we have one in Delhi for deformities.
It is for the oral cancer.
Oral cancer.
Pre-malignant lesions. And
Subodh, you need separate people to do that. If you're just getting one cleft case in a day or one cleft case in a week, it's not difficult for you to yourself report that case, and we've done that in cancer. Now the same pattern can be comfortably adopted by this also. You don't need to really think so much about how to report it. There is a form of registry existing in cancer. The same thing can be copied state-wise by the cleft care as well, and cases will be reported. The second part is, where does compassion and passion come in? I have a thesis in clefts, and I have started seeing cleft babies on the first day of life. Way back in the 2000s, I used to do nasal holding, and we had around 45 cases done that time. The best person to counsel a patient is the person who is seeing the patient and going to be with that patient for the next 2 weeks every time. So the nasal molding guy, that was me that time, used to always counsel. I had a language barrier. I was working in Calcutta with Malayali patients, and I was into Punjabi otherwise. So there was a language barrier which my friends used to break for me. But that is where your support system comes in. The psychological counseling can be best done by a guy who is actually going to deliver that care. I knew exactly what this baby is going to go through the next 18 years. I know he's going to undergo what stage, what surgery. All the anxieties that you had as a parent, I could have comfortably calmed that down. So I am the person right there in the team.
Identifying these persons and getting them together and getting them into units, initially for the city and then probably for worldwide, countrywide, is the main focus here. And I think now we have Seema here.
I will welcome Dr. Seema Kapoor ma'am, who is the principal investigator of the NEEV program, So, ma'am, this workshop is basically to develop an interdisciplinary cleft care network system. And what we are focusing on is that if we can map these services and if we can form a registry of how many cleft patients are born and whichever clinician will be involved in their treatment, if we can map their services, at least starting with Delhi. We have Dr.Ritu Duggal ma'am, who is the chief of CDER AIIMS with us.
So all of us actually, many of us work together. We have worked with us again, and so many of us work together. So I'll just give you a brief on Mission NEEV. It's a program that was actually launched in January 2020, but came into effect from 15th of November 2021. So currently we are working in 31 birthing facilities of the city of Delhi, and the district which is not covered is the south and the southwest district. In the rest of the all the other districts, district hospitals, whether they belong to ASI, railway, government, autonomous, they are all covered under the program. So we currently have samples of nearly around 500 coming to us as blood spots. So in Mission NEEV, what we do is that we collect the blood spots of all these babies, and we have a registry for birth defects. Now in the birth defect registry, actually all the babies who have a cleft palate or cleft lip are anyway being covered in these 31 birthing facilities. So we have a complete data on 1,21,000 population born last year, and we can tell you how many of these babies had cleft lip and cleft palate, or both, or had other orofacial abnormalities. Now the problem with the data will be that it's skewed in the sense that we do not have visible birth defects from NICU babies. So the babies who had some other problem and went into neonatal ICU and did not come to the mother's side and expired are the babies whom we do not have data on. And we can ask the hospitals which are not a part of NEEV, which are about 4 number, which are big ones, to share the data with us. So as far as last year is concerned, that means from 15 November 2021 till date, we can give you a full, complete synapse of how many clefts, which district, which hospital, what numbers. So that's about
That's excellent. I mean, this is something we were looking to have this kind of data, and because that data will be so helpful.
Unfortunately, no one knows, and the clinicians
Yeah,
who
none
are
of us
working,
know here, ma'am.
we don't know about this.
Yeah, so I'm sorry. First of all, I'm sorry for coming late because I had an OPD today, and I was alone at the OPD, so I could not join you earlier. So this program actually looks at point of care testing, that is, and sent out tests. Now the advantage of why I'm illustrating sent out tests is that this sample which is collected, which is about 5 drops of blood on a piece of printer paper, can actually give you a very good feel of DNA. So you can actually distinguish between a syndromic cleft and a non-syndromic cleft. And if you have an X-linked pattern, you can actually just go down right to the gene, transcription box factor 2032, and find out and map the whole family, which may have reduced penetrance. That means they may be having the gene but may not be manifesting with orofacial manifestations.
This is something you wanted to ask. I saw your hand go up.
Ma'am, just a couple of questions. You mentioned 25 or 30 clinics or hospitals where this data is being, or this project is done.
31.
So this is that a pilot project? Is this going? Is it a Government of India project?
Yeah, it's a management.
So this will become a countrywide thing, or is that the plan? Is there a plan?
There is definitely a plan to make it countrywide and to make Mission NEEV. We put NEEV because it's Neonatal Early Evaluation Vision,
Right.
and also stands for foundation. So whenever there is a strong foundation, there is a great nation. That's the name of the program. And since we have hardcore data and we have permission to have all the photographs, whether they were midline clefts, non-midline clefts, what were the associated anomalies, we have a complete photo data for last 1 year.
This is only in Delhi right now.
So no sir, this is also in the state of Kerala. So Kerala, actually, we were a little behind because of critical issues of being in Malati. So Kerala already has a visible birth defect registry, and we are the state number 2 to have a birth defect registry. And in the apart from this, the last 5 years data from 8 major hospitals of Delhi can also be taken over from Dr. Harish Rani and Dr. Rita Gupta, who were looking, and Dr. Shobna, who were looking at the birth defect registry. That will give you a snapshot because that was only 8 birthing facilities, but we have data from 31. But that has been a stage data. We initially started with 5 hospitals, then became 10, then became 15, then became 20, and last month only we had a target of 21, but we were able to cover 21 birthing facilities. And I hope this year we will be able to cover all major birthing facilities.
Ma'am, one more last question. So this looks at only babies that are born in those birthing clinics, right?
Absolutely, yes.
And how many are there in total?
Yeah. So if you look at this from 15th November 21 to now, we have 1,41,000 girls, which are covered completely by all kinds of investigations. Centers, I tell you. So we have all the major birthing facilities: Guru Gobind Singh, Magwan, Mahavir, Ram. You can talk of any number, any hospital. ESI Okhla, ESI Rohini, ESI Basay Darampur, then GTP Hospital, Yadihari Medical College, and Kalavati.
How many have been left out?
So there are about 4 major birthing facilities which have been left out, and the data is skewed, as I told you initially, because we do not have data of the babies who went into the nursery and never came out, or were transferred somewhere, or were taken Lama and were not available to the collection port data. So that data will have that undermining that it is not 100% foolproof data, but will give you a glimpse of at least 90% of the data.
With this kind of data available in Delhi, what left to be done with Cleft Care is to start mapping those services where these babies can be referred to, and not just to one hospital that okay go here, but for a comprehensive care. You know how the clinically
I think one problem is partially solved. That we do one registry is existing.
So this needs to be scaled up.
Yes.
And how and when can we open it wider to like Karnataka, Tamil Nadu, and other states?
Politics is every state nodal officer has to take up that.
Who should take it up? Who should we approach if we were to start a proposal?
So the National Rashtriya Health Mission, that
NRHM, the director of NRHM.
There is a state program officer for child health. So
and that part I told you a little bit, so that is for all the programs.
So if we approach this NRHM for our state and come through them,
They have a state program officer, or the designation might be state rural officer for all the programs. It already exists for all the states. I told you the funding is 60% from center and 40 is given by the state for the entire health program.
So we just have to convince our state to give 40%.
Yes. So they have to move in the state-wise.
So there is, you have to ask who looks after RBSP.
Yeah, in that particular
Rashtriya Bal Swasth Karyakram, which actually covers defects, delays, deficiencies, and diseases, right? So the defects part of it, which is Cleft, is very much a orofacial, other orofacial abnormalities also are a part of that registry. So you have to go back to your Rashtriya Bal Swasth Karyakram person, and that person will be able to help you penetrate the disease. I think yes, as sir is saying, we can get the list from.
We can get it from. Luckily, we are in Delhi, and Imam is in Delhi, so we can get the entire list from the office there. We could ask Dr. Swastik Charan because he's handling so many programs, so Swastik Charan sir can give us that list.
I just have a question, ma'am. Dr. Seema, I just have a question. The thing is, this NEEV and RBSK are 2 different initiatives, right? It comes under the RBSK.
It comes very much under the RBSK program, and as a part of, to make it a little more impressive, we named it as Mission NEEV, but it's a comprehensive newborn screening program. The components I told you are 2. So the on-the-spot sampling is done for congenital hypothyroidism, congenital adrenal hyperplasia, and hemoglobinopathies. And the defects which are observed are retinopathy of prematurity, critical congenital heart disease, hearing, and visible birth defects. So under the visible birth defects comes the clefting, and for that we have real data. And to substantiate the data, we have followed these children up actually at various time points as to what happened to them, whether they got operated or not. So are they still in the line? So that hardcore data is also available for the last 1 year.
Just a follow-up question on that one. I know blood samples are analyzed by specialists, but rest of the visible defects are examined and diagnosed by whom in these birthing clinics?
So what we do is that usually what happens, this is the sad part of it, that we call all these babies to Loknath Hospital, and we have a VBD form. we fill up the visible birth defects form, and each of them is analyzed by a geneticist to look at whether it's syndromic or non-syndromic. And then once they're non-syndromic, they are put into line at regional hospitals for oral care. But that care is pretty suboptimal, and something like this is really needed for each visible birth defect to be streamlined to the right
For reference.
for reference. Once you identify, our job ends there actually. But since we have to, for the northern district, we refer them to Dr. Arpita and Dr. Monica Juneja, because that is COE LNH. But for the rest of the babies, we have to identify what regional hospital, whom to address, so that these newborns who are pretty tiny and have temperature issues are not kept in a waiting line when there are many other things to be addressed. So a holistic care is definitely required.
I think with ma'am's coming, the entire discussion has taken a new dimension, it's gone into a new route, and we really need to look at where are these centers where we can refer them to. Where are these centers? Can we
I hope I would have, I just get a snapshot of the districts. So I would have all the districts except Southwest district. All the districts except Southwest district, I mean AIIMS and Sarojini Hospital have to be included. So these are the two hospitals which are remaining.
I think, ma'am, she is asking that the centers where to refer them. I think
So
that you have not,
that mapping has not been
yes,
done. That mapping has not been done, and that mapping is required.
This is just the cases which they came across in that registry.
No, in that
birth defect registry, and this was a program which was initiated by Niti
Yes,
Aayog.
you're right. I'm talking
yeah.
about the centers where these babies can be referred to.
No, that's what is now we have to
Yes,
identify.
yes, that is what will be the work of this.
That's your basic agenda. If you plan that up, we will follow it as
Yes.
the committee says, and that can be referred.
I understand Dr. Ghosla Reddy has to leave shortly. So I understand that you have to leave shortly. We would want you to give your recommendations towards this center before you leave. Your recommendations are important, so we would want to take your. So the mic.
In fact, I was enlightened a lot today, especially on the neonatal part, the great role they can play for us in the cleft care. I would thank all the neonatal specialist colleagues who are here to really enlighten me, and especially Madam, after she has informed us about the role of the government and already the process which are going on. Yes, I think this is where we need to create a platform between the policy makers, that is the government, the organizations which are already involved in working towards identifying these congenital defects, where we can highlight this visible defect of cleft and clinician anomaly. It's just not only about cleft, but even the other anomalies of the face, orifical cleft. And then also at the same time trying to include this, the early identification in the neonatal aspect through the government itself, and then to collaborate with the existing what you call the comprehensive cleft centers. Of course, the referral can go down to everyone, there's no bias on that, but identifying a comprehensive cleft care centers where here it's not about surgery, but as Madam has used the word called holistic management. That is what we need to look at. They get all the surgery, orthodontics, speech pathology, everything that is needed for the next 18 years. That's one. Two, yes, the RPSK, they're all trying to identify during the birth defect itself. But there is so much of patients that have been already operated over the last 25 years, which have not given the holistic care. And these are the children who are going to the school, who are in the institutional studies. They can be also identified at the same time, even guided to go down for the comprehensive management. I think we have to also discuss about not only about the primary, but mainly about the secondary rehabilitation. That should be also stressed upon in this coming up discussions. Thank you.
Thank you for your time, sir. I understand you have a flight and you need to rush. Thank you for your words. Whenever you need to make it.
Ma'am, we have the leads of cleft centers in India who are having a holistic centers. We have Dr. Subodh, Dr. Ghosla Reddy and Dr. Krishnamurthy. They are having a center in which they have a speech therapist, nutritionist, dietitian and a counselor. And these are
Dr. Sanjeev from Gurgaon.
Yes, Dr.
We also have.
Almost all of them.
Yes. The ones who are here, they have a comprehensive center.
Only in Delhi, very important.
Yes.
Very important.
Let's say only one thing, she's doing a very fantastic job, and we see her day and night that how she's passionate about it. But what I want to know from you, madam, is that there are three issues. One is that is there a sustainable model to this? Because then it should not die off like various other projects we have been discussing. We saw what happened to the WHO registry also. And second is we should all know that once going into collecting this data, as she said that there is a coordinator in every of these hospitals who is working from 9 to 4 collecting the data. So do we have some model which can sustain these people, because they are actually the people because of whom you are getting the data. The moment that support is withdrawn, again we will be left with minuscule data or low quality data. And third is, does this project have some quality check? Because we are totally dependent on these coordinators. So if the coordinators are not reporting any baby with cleft palate, then how do we actually do a surveillance on them?
So I think all the points very well valid and well taken. These are they have been trained to look at the ISP coding, but yes, like soft palate, soft clefts, obviously would go unnoticed. And we currently do not have any quality assurance program inbuilt in this. So maybe that is one suggestion we take forward, Ashish, to involve you, since you have been a part of the World Defense Registry for last 5 years with WHO. So how do we manage the quality checks, since I have only one pediatrician working with me, and maybe we can develop some quality check programs, and maybe we can write to all these working facilities to give up the data on regular basis. And it's not a very difficult step, because every resident is examining all the neonates at birth, and these are quite visible birth defects. So actually they don't require a collection coordinator. There should be a mechanism of reporting the birth defects by the hospital to the government, so that not only you can map what are the pathogenic agents in a particular region or the environmental causes that can cause this type of birth defect, which we really don't have. So to answer both your questions, the answer is no. We will have to look at, and for the sustainable model, yes, I'm living for it, and I'm trying to make it a sustainable model. That's the only promise I can give you, because I'm not with the governmental side to make this a mandatory program, and we definitely look forward to your advice for quality checks.
Is there a timeline that you have? Does the government say you have money for 10 years, 15 years?
Or is that only 2 years?
With this information that we have about data coming in, at least in the city of Delhi and then the state of Kerala, with this information, what can be done by us clinicians who are dealing with, I will call the clinicians actually grassroots level workers, because we are at the grassroots dealing with the patients. What can we do to bring in teams together? Not just about establishing centers, how can we collaborate?
Can we create a dashboard where the services are available?
A portal, you had an idea of a portal, at least for Delhi.
So as a clinician, what happens like in my hospital, there are almost 2 cleft palate babies every maybe 2 weeks or so. So once the baby is born, they are counted by many agencies. It may be NEEV, it may be our own data, it may be some still thriving WHO surveillance data. So the counting is done amply. And if you go to any Delhi hospital, some or the other way they are counting the babies. The problem comes with the cure. So now once we identify these babies, I think we should develop a dashboard of services.
Yes.
Services in domains of all holistic care, what you're telling,
Yes.
in terms of speech, in terms of counseling, in terms of surgery, in terms of whatever. And those lists should be shared maybe with people like Dr.Seema, who have their percussions in all hospitals and coordinators, where we can actually transmit. The other most important thing is the team for the management has to come on site before the baby is discharged. Suppose I discharge the baby and give him 2 numbers or places to go, then it's a difficult job to get the work done. At the same time, if you have some floating team, I don't know how we generate that team, but I'm talking about the ideal world, who can move into my nursery when I call them. Maybe he can just give 2 hours a week, so that, because these patients are connected to me, they're my patients. So suppose they tell that on Monday we'll come for 2 hours and counsel and advise the roadmap which is there for the cleft babies. So that would be a great help in translating that advice into actual help to the patients. But just giving a dashboard and numbers and hospitals may not translate into services, to the end. That's my.
We need some inputs from these speech therapists.
Can I
As a
respond?
teacher, I'm a
Can I respond?
gynecologist. I'm sorry, sir. I think sir, the medical skills.
To answer your question, rather than giving patient the numbers, most of our multidisciplinary centers, many of them supported by Smile Train and they have coordinators who are looking for patients.
So we need
If
to
you
have their numbers.
give the patient's number to them, there is a possibility of connecting a little bit more.
So because they are the most knowledgeable persons. As a clinician, I have to look at cleft lip, you have to look at meningomyelin, there's so many other things also. So that way I'm a very diffuse person, not focused on cleft lip, cleft hand. But if that coordinator comes in, then he knows the whole game, how it is done, who is the correct person, which are the able centers. I think that would be a fantastic service.
Like for instance, at my center in Chennai, once village health nurses, we have a kind of arsenal kind of thing where they have a chart to identify. See, all of them, they are in charge of 5,000 patients and not many babies are born. When a baby is born, they are able to identify a thing. Now they send it to RBSK. Previously, they would call us and give us the information. So we are
have
able
one
to tap
that
into the grassroots.
As far as the counting is concerned, you will have a lot of countable babies with all of us. So I think we should try in Delhi at least.
In a city like Delhi,
Can I suggest something? Like you are saying you have different centers who are providing these services and different clinics at all over across. We have a e-dance portal which is working for Government of India. So I can get all those clinics mapped in e-dance portal. If you select if you send your services there, that's my job.
So we wrote you at the right time, ma'am.
Can we have your number back?
You just have to send your information. Like center from Chennai is giving services for this. So anybody who is looking at cleft care, if somebody, that is for patients as well. So that is for mapping your services across where you are staying. So if any parent looking at the cleft care, so you are the nearmost center for them. So that mapping I can get it done through that portal because that portal is with the All India Institute of Medical Sciences being the center for excellence. So that much assurance I can give. I can initiate that. But in that case, it's not that we are giving you the data. You are mapping your clinics and your facilities in that.
So before we go, how do we get in touch with you?
To us. We will be. We rather it's an open invitation. We would create a platform there for cleft care. So anybody who knows that the service, maybe you are the one, or like she knows. In and around Delhi, there are the centers which are providing those services. Not only orthodontic, surgical, speech therapists, all the team can be mapped there. It can be, and we have different portal for different states. So it can be done through the state networking as well. Primary aim was to map the dental care facilities. Now the facilities which have cleft care can also be added to this. It is not very difficult.
You just have to go on to e-Dem Seva and then you can. It's already existing the site there, and then we need to add a portal.
It is open for public. It is open for anybody. They can just map the services in and around them. It's only that we have to say that yes, this center is also a primary center or a tertiary center for cleft care.
You need to recognize.
Yeah, we need to recognize like yes.
We can send in a proposal to let them recognize this, and then the centers can map themselves on the.
But till date, only the government centers were mapped in that. We need to take a prior permission to map the NGOs who are into this. Like if Smile Train wants, I can initiate with the government that we will map for this facility the centers which are funded by SmileTech or any other or NGO. That has to be, but I need a proposal from that. I will initiate from the government. That I can do.
Puneet sir.
Just a few points to make. Actually, I think there are 2 points which we need to discuss further. All the points are so relevant and it's a big issue. We are talking about mapping in Delhi, then rural areas, then subsequent areas. So it's a big battle, but this is the starting point, and I must compliment you to have initiated such a talk. I want to inform you that Smile Brain recently under Dr. Krishnamurthy, we did a program with FOGC, which is the Association of Obstetricians and Gynecologists, to educate them about the timeline of treatment. Because I feel the biggest challenge is even clinicians being unaware of what kind of treatment the cleft child has to undergo. So, at the onset, they were told about what all things can be done for a cleft patient to get a normal life. The other issue is that, recently we are discussing a point on patient-centric care. We are all talking about clinicians and very good centers providing quality care. But what is quality for the patient? Are we involving the patient into our care? In fact, this started with a discussion in Edinburgh, where we had the International Congress, that one of the patients gets up and she says, all along, my parents were being discussed about my treatment plan. And I was not even looked into my eye to decide whether I want that surgery or I want that procedure to be done. There is a timeline for treatment. So I believe that in the data which we are thinking about, or we are Dr. Badri was talking about the challenges of a 5-year-old, and we were debating whether 6 or 8. There is one aspect which we are totally omitting, is patient-related outcomes. We need to add on to our data management as a very, very important component. Second thing is that we did an analysis. We had 130 centers. In fact, we are just about to present that on 23rd of March. So 130 centers from high income countries and low income countries, and a lot of clinicians from India also. So we found that lack of knowledge is very high among even us. So I believe that the first and foremost thing which we can tackle, say telling a government to do a program or telling a particular agency to fund it further, is not in our hands. As clinicians, the most important thing in our hand is knowledge and disseminating that knowledge. Making protocols simpler and trying to transmit it. Second thing is that clinicians in the developing world have little time. Talk about Dr. Krishnamurthy's OPD, or you talk about Dr. Altaf, or for that matter Dr.Subodh or Ghosla, they have no time, because 1500 surgeries, 2000 surgeries in a year, it's a phenomenal number. So we need to look for how to accommodate that data gathering thing which we were discussing, which is going to be actually the outline for deciding on treatment. Resources, getting government funding itself will not be an outcome. My suggestion was that, many years ago, in 2012, I set up a parent association.
Yes.
So it is called Cleft India Parent Association. Can we link up all these parts of the country with the parent association, so that, the kind of support we are talking about, like you mentioned, it is very important to give, not from our doctor perspective a support from parents whose children have been treated. I call them cleft warriors. They are the people who are supporting each other. So could we do something on that front? Another issue is, patient follow-up. Everybody, if you notice, a patient might get treatment done, bone grafting done with Dr. Ghosla, and then move on to another surgeon to get a secondary surgery done or a tertiary surgery done. So when we are talking about patient record and having a portal, the portal will serve that function. The government is also trying to set up a portal where all your health records are there. So you move from one center to the other, there is some information which is already there. So we need to think about something on that line as well. And the last thing is that lack of support in terms of clinical outcomes. In terms of when if you talk to me as an orthodontist in Delhi, many patients are not aware that they are getting quality service of orthodontics. And if you will, like very rightly said, can you tell me 5 teams in Delhi which will actually cater to cleft care? There are no comprehensive teams available at one site or one place. So there are some things which we need to consider in a big way if we want to make this the next step.
Yes, sir. Thank you so much for this input. And I think all the points you raised are relevant, and definitely this workshop is focusing on developing those teams within Delhi at least for now. We have centers in Amritsar and Gurgaon. I think we would like to hear from their experiences.
I'll just say one thing. In fact, I mean, as much as we would like to hear that, I have a submission to make. It's not that the patients don't know where to go, they really don't know what to do. They are taken there to the centers or respective centers. Unfortunately, that's the case. Now, even if we have these services, it's very good to be accredited by government bodies saying you are on this portal, you are on this, but the patients don't go by themselves. So that's the first thing. We need to identify where the patients are. The important thing to start with, I think, there was a few years back at the Union Ministry's department itself, the Union Ministry of Health, they had a small council where a lot of cleft care NGOs were invited, and there were a couple of meetings, but that slowly fizzled out over a period of 2-3 years. So what happens is, the best thing is, I think, more than where the services are being delivered, it's important to identify, as the registry would be the first thing. And the registry could start small. Instead of a project mode, you can actually look at the largest chunk comes from the NGOs as well as the government programs. RGST also funds some cleft surgery. So if this itself can be collated by taking one of the government bodies, I think that's where we can start and look at for newer data rather than going back to old data.
Yeah, that point is very good.
I think we can include the speech therapy. We need to hear from the speech here.
Hello all. In the perspective of as a speech and language pathologist, our work starts just like when the child is born. We can actually work with the feeding issues, right? So the speech therapy as written is starting from 2 years and above, right? But as the child, because I deal with feeding issues as well. So the child with cleft will always come with no reflexes. The oral reflexes are very rare in these. Maybe it can be sucking, it can be tongue movements. These are the reflexes that are that should be there while the perinatal time, right? So when the child is born with cleft, so they don't have any such reflexes, right? So in the beginning, we can start with oral stimulations as well, right? Oral stimulation, tongue exercises, tongue stimulations and all. So that will actually prepare the child for further feeding. The child will not have any feeding difficulties, right? So with the orthodontist and all the surgeries that the child will go through will always help. These exercises, these stimulations will eventually help the child in feeding as well as in speech, correcting the speech. There will be rare speech errors, which eventually the child will have in gradual times that we
You do recommend that the speech should start?
Yes, it should be, yes, exactly. As Dr.Altaf said that nutritionists and nursing, feeding nurse, and everyone is there.
So, but we also want to know that, okay, you are at the Maulana Azad, you are in
yes,
you must be seeing patients coming across to you.
Yes, but to be very frank, not
who are the others in Delhi who can do this?
Yeah, exactly my point. But I'll be
Chetna is here from Sant Parmana.
Yes, actually ma'am, 2 years was written in this picture. We are doing counseling till 3 years. After the cleft palate surgery, we are just counseling the parent to do these concepts and counseling the parent to do the modeling and imitation with the child, so that the child will get the language at the age of 3 years. After the age of 3, we will start these speech therapy sessions and assessment in the therapeutic management as well.
The child will always have oromotor issues, right? So which eventually processes, prosthodontists and orthodontists, and if everyone as a team we work together so that the child will not eventually have speech errors. Right, so
the child has to be referred right from the birth.
Yes. This is my experience in Maulana Azad, because we've been going to NICU and all, seeing all the feeding issues, and when the child comes to CDC for follow-up, we do see a lot of difference with just few stimulations that we tell them initially. So cleft patients can always be a very good patients, and they can actually be good with oromotor. Stimulations can be done in college.
That I think is a valid point that we start them at birth itself.
Yes,
we are more concerned about mapping your speech services in Delhi.
That's what the services is a major issue in my fraternity, because many tertiary care hospitals don't have speech therapists. Because I don't know what is the reason.
So
The many
in your college curriculum also, is Cleft taught as a separate?
yes, it is. It's a different altogether a different.
section.
Yes.
So there must be people who are specializing in this.
There might be, but talking about the manpower in our fraternity going to all we don't have much of speech therapists working in good hospitals. And they're not trained.
They all leave India and go, they get good jobs.
Yes, no doubt. Yes, sir, that's what, because there is a problem. This is the major issue because I used to work in St. Stephen's Hospital before under Smile Train. So, Parmanand also one of them. So, problem is that we don't have any streamlining things.
Is there a council or somewhere where information can be got of who's there, where?
As I think ma'am was saying.
Cindy, can you recommend 5 good speech therapists in Delhi?
$1 million question.
We recommend to Ritu ma'am. If
Yes,
she
ma'am. Actually,
considers.
there are many private institutions, no doubt, which work not specifically in CLP, but they also cater to these patients. Like I also used to cater to CLP patients, but right now in MAMC we don't have that streamlining. But eventually, right after this, we'll always talk about it and we'll streamline this so that MAMC can always be there in one of the talks that we are having.
You have 3 concerns: feeding the child,
yes,
getting
Teacher.
reflexes,
yes,
and psychological counseling.
yes, sir.
Sir, Peter, sir, nasal molding solves the 3 purposes. The baby sucks in the incubator even on the second day when we take an impression. The reflexes are there. I have had low birth weight babies. I have the photographs still maintained, they're published,
Yes.
indexed. Sir was the editor that time, I think. 1 kg to 4.5 kgs within 5 months because the plate helps you feed. Counseling I already mentioned. The best person to counsel is the doctor who knows the timeline of the surgeries. You can pass it. All 3 can be concerned. You can delay speech therapy till 10 months or so. I'm saying that because of the paucity, because orthodontists are not in paucity.
Yes, sir.
Orthodontists are not.
Yes, sir. Yes, sir.
Point is
Just
very
we can just
valid.
be a
Because
good
of the
help.
paucity of availability of speech
Yes,
therapists.
so
This
this
can
one
be
and I'm a surgeon, by the way. I'm a surgeon. I have some training.
But we can always be a part of the rehabilitation.
You are
From
always
the-
you have to be.
From the beginning.
There
From
is-
the beginning.
You have to be. You
Yes,
have to be.
from the
Because
beginning.
of the paucity, these things can be addressed.
From the
by-
beginning. Yes.
Yes. So it's definitely, I mean, from the beginning, we want it from before the beginning also.
Yeah, yes,
The
yes.
point is a lack of these
Yes.
persons. I really want to talk to, get inputs from the high volume centers of how you can be a part of this mapping of services. What can you do? Now we know that we need to map ourselves. The centers I want you to. Yes, we want to hear from Subodh sir, Sandeep sir, Kanu sir also.
Before I go to the mapping, I want to say a few words about registry. So far, as has been told by various speakers, that all the efforts have been done in isolation and in project mode. And if we continue that way, this will not serve the purpose. We have to look at the country as a whole, and if we are going to ask the government to include this in a national registry, we have to prove that this is a public health concern. So we probably won't be able to do that. It came out of the WHO priority list. So, but something that should concern all of us is all the congenital anomalies. Like we have registry for TB. All the TB cases have to be mandatorily registered by anybody, private sector, government sector, anybody who sees the TB patient has to register. Otherwise there is a penalty. The same way we should approach to the government that all the birth defects must be registered wherever the birth is happening, wherever the child is being noticed first, and that should be linked with the mother's Aadhaar. And when the child's Aadhaar is also there, that can be added. So adding it to the mother's Aadhaar will be very important, and especially if the government is coming with the health record of all the people, so this can be portable. So if it is linked with the mother's Aadhaar or the child's Aadhaar later on, so all this data can be portable, and you can check whether this has already been registered. If not, you can register if it comes to your center. So that way we can take care of the registry, but not in isolation for cleft, but for all the birth anomalies. And from there, as an offshoot, we will have all the cleft registries, and that data we can make use of.
How is this possible? How can we make the government, you're writing a proposal, of course.
This is what they have done in Cancer Atlas.
Yeah,
this
see,
is exactly what is done in Cancer Atlas 7 years back, and that's what I said initially. Ma'am came in that time, so we
see the total burden of care of all the congenital anomalies is much more compared to the cleft alone. Right?
So they are doing, right? NEEV is doing the same thing.
Yeah, so many centers have done it in isolation, in project, and in smaller numbers. Like Tamil Nadu has done already, she is doing it already here. So this has to come at a national level as a big health concern of all the congenital anomalies. And from there, not only cleft, other things, heart disease and other things can come as an offshoot, and you will have a national data of everything. And this has to be linked with mother's Aadhaar, and later on the child's Aadhaar can be added. And then this can become portable. Now coming to the mapping of the centers, and I would like to draw attention of Madam Duggal, and she said that only the government centers can be mapped so far, and as far as NGOs are concerned, if they apply to us, we can take a note of it, or we can think about it. We have to see health as a national problem and the resources as a national resources, not as a government resource, NGO resource, and a private resource. We are all together.
Very true, because most of the cleft centers we have are all private.
Yeah, so see, we are contributing towards the national health. We are not competing with government or NGO or private sectors. So this is a national resource. Why are we dividing it? So we should be mapping. Let me complete.
For that, I need to take a permission because it's a
Ministry
of Health.
I'm just airing my views.
So
I'm
it's not me who said that.
It's only organization.
Yeah, so I'm just airing my views, not just you do, the government should do it, right? So we should map, as has been mentioned in detail, we should map all the comprehensive cleft care or individual cleft care available at different centers in different states, different districts, different kinds of hospital, be it private, be it NGOs, be it government hospital. So we should provide all that information to the patient, right? So anybody can access that patient, and then it will be useful in the country. But we should be thinking in a larger scale. We should not just think in a smaller project or a smaller state. So we should, when we are already too late. Say it's 2023 and we are not doing it, right? We have made several efforts and failed. There's no more time to waste. We should go ahead with a broader project right away to the government.
Excuse me, sir. I would like to add here something. Sir, as mentioned, the first point, as a very valid point, was adding that birth defect to the mother's Aadhaar card. What I recall, Seema ma'am would also agree, there is a program under RBSK called as Hridayam in Kerala. It's already in place, and they are actually registering these babies with critical congenital heart defects, and they are linking the child's this special ID, whatever they are getting, with the mother's Aadhaar card. So it's already in place.
Some things are already in place.
Yes.
Fragmented.
So does the mother also get, through artificial hair, something, the services that are available?
That I am not sure, ma'am.
What is the benefit of adding into the Aadhaar? What do we gain? Do they get any subsistence or any other?
So they would be identified easily.
No, the primary aim for adding to Aadhaar is to get reported.
I think that.
And not duplicated.
Duplication will be seriously avoided because they would go to multiple centers. If they are linked to the Aadhaar, the multitude of visits maybe narrows down the patient to a realistic number rather than 3 different districts. So we tried to develop this app, which is a mobile app, where you could actually link a mandatory feature was the Aadhaar of the parents. Because what has happened with the rare disease, I will just relate to you. So, as you said so correctly, the patient support groups became so vocal and so much demanding that they went to the ministry and they helped create a policy for the national rare disease, which was tabled on 30th of March 2021. Now you would be surprised to know that this registry provides treatment for patients up to a sum of rupees 50 lakh one time.
What diseases?
So the diseases are rare genetic diseases, and they are grouped into small. Those who require group 1 is the one requires single time treatment like liver transplant, kidney transplant, or a kidney and liver, or a bone marrow transplant. Second is recurring short term or long term therapies like growth hormone, immunoglobulins. And the third one is major chunk of rare diseases like storage disorders like Gaucher disease. So we never thought that was going to be possible, and just on 30th March 2021, this policy came open, and the first set of multiple crores have already been distributed to 8 centers of excellence, which have now gone to 11. And besides, every state will have a center for excellence. Fortunately, Delhi has 2 centers for excellence. One is AIIMS and the other is MAMC. So we have put up many patients in the portal. So if the registries, I would say, become a very important vocal part, the government will listen to the patients much more than they listen to clinicians.
We have something called the Cleft Collective in the UK. The Cleft Collective is exclusively run by the government, but exclusively for patients. So they have patient groups in it, and they meet, patients meet every month. And there is a closed network group, and the advantage is every patient born in UK with Cleft are registered, and they are linked to the Cleft Collective. So all they've got to do is go into the website where they'll have dedicated people giving them one-to-one conversation. They can come in face-to-face. But the funding is enormous, probably much more than what clinicians get for treating patients. That is more important for patients themselves. If we can do something similar to that here, that might also.
I think getting the patient support group working in any field of congenital malformation, I definitely agree with sir. Orofacial clefting is one part, but we would be debating on meningomyositis and many other things. And once you get the patient care group support, a strengthened policy, if they can talk to the government better, then we can negotiate with the government.
We still to hear from Kamlesh ma'am, Sandeep sir, and Kalu sir. We still to get your recommendations. We'll start with that.
Mine is Comprehensive Cleft Care Center, Vivekanand Polyclinic, Lucknow, and we conduct camps to screen the cleft patients. And because of social media, we also get, and there is mouth referral because it's a center working since more than last 10 to 12 years. And we have the bus also. We screen the patients, we carry them, and admit them. We provide them travel expenses to and fro. They get the food, they are admitted, the surgery is done, and then they are being sent back to their places. We have pediatric care, ENT care, and speech therapist. They are round the clock. Orthodontic services are round the clock, and we have recently launched nutrition program that is also with us.
Ma'am's center needs to be mapped. Ma'am is just saying that my center needs to be mapped. Definitely mapped.
Orthodontics, that is also very well going on.
Yes, yes. Thank you, ma'am. So we would like to hear from you, especially because you're running one of these monitoring centers in Delhi NCR region. Though you're in Gurgaon, I would say Delhi NCR region. And your contributions in
before
Delhi.
I start, I would like to ask Panchali, when you said that you wanted to develop or wanted to know about the state of Delhi, and you wanted to pinpoint what are the resources available in the state of Delhi. So when you say Delhi, does it include Delhi NCR or just Delhi?
Delhi NCR.
Delhi NCR, yeah. So we are one of the centers in Delhi NCR. It's in Gurgaon, and it's been there since 2017, and it's again a comprehensive cleft care center. We have surgeons, orthodontists, since it is a university which has a dental and a medical college within its campus. We have all the facilities of a dental college which are available to us. We have a dedicated orthodontist with us as well in the cleft team. We have a speech pathologist, we have a nutritionist. We do run the Smile Train nutrition program as well in our center. And what I would like to say, is that we actually collaborate very closely with the RBSA, which is very active in the state of Haryana. They have these district early intervention centers which have been set up, and we get referrals from about 9 such centers. I am directly in contact with the center heads, and we send our PROs to them whenever they ring up and they tell us that they have cleft patients. They need to be transported to our unit, and that's how we work. And once they're operated, they go back, and they're automatically registered with us in our database, these patients. And now that SmileTrain has made it mandatory that we should include the income certificate of the patient's parents. So somehow even the Aadhaar card and all these identification and income proof certificates are also linked with that. So we have a good database of our patients and their parents. Since most of our patients come from a low socioeconomic background, and a lot of them are migrant laborers whose children get treated in our institute. People from Bihar and all, they get the children from the villages, get treated, and child is sent back. So since it is a new center, we don't have longitudinal data of our patients over a period of say 10 years or so. Many of our patients, they come for secondary corrections, primary corrections of course, but they have had their surgeries done elsewhere. And I think one of the purposes was that you wanted to collect data so that you could compare the inter-center results so that you can come up with a recommendation on what to do for a patient. But that is probably not possible right away for us, because since not all surgeries may have been done, or not all treatment may have been done for each patient at our center itself. So that is what probably will be done in the future.
So would the services be available free of cost?
They are, since it is SmileTrain. For patients, because now income certificate is mandatory for patients of low socioeconomic services. You cannot, there's a limit.
Many of these patients may not have an income certificate, so
they're
procured. So they just need a ration card. There are a number of documents. So if you don't have a document, they just have to sign that their annual income is less than 8 lakhs. There is an exception for that, but generally there's a list of documents. The common one is a ration card or a BPL card or whatever. There are about 20 odd documents which are
like in Delhi there is no SECC categorization. Like many other states have the SECC categorization, but Delhi does not have this SECC categorization. And many of these patients may not have an income certificate. So
they don't need an income certificate. One of the documents, and in the absence of everything else, they just need to give a declaration, and then the project director has the powers to get them into the scheme. Yeah.
This is a new development, Madam Chairman. There are some really, my patients have sometimes come in on the accord. I've got free surgery and free care done. I mean, we never asked for it. Even now we really don't ask.
This is a new requirement. I believe it has come from the funders. People who are now funding the NGOs are asking this question: is it going to the people who really deserve it or not? That's why it's
this is also from FCRA compliances, so that you are actually helping the needy people, not passing on the money to them.
So we'd like to hear from your.
I'm also working with one of the Cleft Center, which is being completely funded and supported by the SmileTrain. In SmileTrain, we definitely do have a kind of a registry, because we can track a patient from the day one when they report to us. We do their nasal molding and when the late palatal surgeries. So there is a complete tracking of a patient with a complete set of data, which is there. Which is the point, which is that we definitely should have a registry, so that we can track a patient that this is born with cleft or any other congenital problems, and are they being treated for all those things? Are they being referred to them? So having one common registry was something which we definitely find it also in a SmileTrend system also, or putting it up that we get a same patient but with two different numbers. So it has to be that anyone, like such as that it should be linked with the Aadhaar card of the mother, so that there should not be any two, the same patient getting the two registry numbers, so they get benefits, and then we can really track them. So how to figure it out? That's a very critical. That's a crucial thing. That one app or one thing, or at least the first centers which are working, they definitely should start bringing in the patients that these are the patients who are having problems. Second is it not only the things. I have been into a center where we have operated a cleft lip panel who is around 40 years of age. It's not usually happening right now, but 5 years, up to 5 years, we used to have patients who were being not treated. And again, it's not that the congenital problem. There are those patients who are not been registered, or they even don't know that they can get their things done. So again, the point of is mapping that those areas. Like in our place, we get patients who are around coming to us, maybe traveling for nearly 1.5 days or 2 days, far areas from J&K. And if they know their family is somebody around them, they tell them. Sometimes we have seen patients who report to us 3 years, 4 years down the line. So certain things they have missed out on that. So definitely registry from everyone, starting from the gynae, if they are, or radiologist, ultrasonologist, or anybody who is there, they should keep reporting, but at one point. So it should not be at a multiple point. Even if it is a multiple point, that can all be integrated to one.
There will be a challenge in that.
Please finish that point.
Second, like I come from Punjab, and it's a state to talk about, and I can count on my fingers that any orthodontist who is involved in the cleft care. So where Dr. Puneet had also covered that we are having a very acute shortage of certain resource persons who are going to do that. So mapping the centers and persons who are going to provide those things, barring 5 or 6 in whole of Punjab where I can figure. There are a lot of orthodontists, but definitely as ma'am was saying that, as you also said that, somebody may not have the passion to work on such kind of patient. So that is also very, very important. It's not only that we are going to figure it out how to do it, but we need to train all the specialties which are involved in treating such patients, that we have adequate number of those people giving them the services. We cannot map all those centers unless and until we have the resource persons and people performing those things.
And I think we are those resource persons. Everyone here is those resource persons. Is there something you want to do?
The challenge would be that these industries are state-wise, I believe. Am I right? So when they are state-wise, that happened in Cancer Atlas, so I'm aware of it. The same patient will go for surgeries repeatedly elsewhere, and there will be some amount of duplicacy. I don't know how far the Aadhaar card linking can solve it, because they are going to be maintained in separate centers. In Cleft, it's going to be more, because we are going to operate a patient 8 times. Cancer maximum once or twice, and then unfortunately we not be there after 2-3 surgeries or so. But here all these patients are going to have multiple surgeries. The duplicacy will be an issue despite all this.
Yeah, that will be issue, and I think we'll have to come to it when we reach there.
Yes.
We're still not there yet.
At least we should start recording that registry is mandatory, and as sir said, it should be a law. You have to put in, you see a patient today, it has been operated thrice, you just put in the numbers, it will appear that this patient is already registered, your job is over. And that has to be done by everybody to see the patient. I see one patient in my private practice in a month, I have to register that as well. So that's the case.
Yes. We're coming to the end of this panel, and I've just put up some points of what was discussed today, and I'd like to just summarize, and if anybody wants to add, tell me anything and I'll add to it. Because this will come out as a minutes of meeting, will be circulated among all of you, and we plan to incorporate our recommendations either in the form of a report or a letter and send it to the ministry, which has sent us the funding at least.
at least to that ministry and wherever else possible. Because we, like everybody said, that we don't want to put an end because the project is over. This should not be the end because the project is over. We want to send this. So, ma'am, before you came, I think we talked about lack of information, lack of knowledge among patients, and lack of information of available services. I think that was the first thing that was there. So, we had to address that. Dr. Ashish mentioned about the dashboard. Nobody is updating the dashboard which was there, because again, the problem there is the project is over. Lack of a central registry. These are the lacunae that we found out. Is it possible to use the PMPP form to recognize? Is it possible? No, it's not possible. No, it's not possible. I'm part of the PMPP Delhi team, and that is a very something which is a medical legal document, and the reporting there is not very detailed also. We are supposed to report, but it's not so detailed that we will be able to identify specific.
So that's going to be out. So I don't think the report should mention anything about PMPP.
Yes, we refrain from
mentioning that also. Okay, I think we'll take that out. Prenatal counseling, I think we had a very good discussion on that. That's a very important part.
One part I think which is really needs to be looked into, because the referrals, like not just radiologists but obstetricians and fetal medicine people.
Yes.
And Dr.Seema Madam is there. That madam in the prenatal, we are the first people who have to counsel them. And we can offer them some services like the genetics, because you are going to see the live babies and then decide whether this is syndromic or not. But that would be done in the prenatal period, and that would be a great help to the patients.
I think so there should be something which, in terms of the moment the radiologist or the sonologist sees it, the patient is going to be asking them what next, after the delivery what next. So there should be something simplified, as we had that in, speech therapy this month or this many years, this surgery, this. So that once as a sonologist one has seen a problem, we'll be okay, this should be this, and this is what one would have to go through in the beginning. And then the later part of the things can be taken up by the other specialties. So there should be something very simplified. That's what I wanted to ask in between also. All these things, if they have a website, there's a problem of how they're going to be joining the private agencies. I think so the moment there's a problem, and we can always guide them, the patient, get onto this website, you'll get a little more information. Then automatically, I say if they're not 15 or 20% who are not able to inform from the private sector, they would be then 10%, because the patients themselves would be interested in knowing so many details. That's correctly said, the available services, but what has to be done is important.
The treatment protocol is fairly standardized across all sectors. Yes, and I think what we're all driving towards that, there should be a portal. I think everybody agrees to that, an app or a portal or a website where information is given as well as services can be mapped, or linking to a portal that's already present with the government. I think that would be the need of the hour.
And if we have an app, doctor, that would be really good, because everyone has a smartphone. The patient themselves can just go to the Play Store and download it, and we all should be aware, yes, there is something like this, and automatically the things come on.
Yes, of course, but these apps, I think when they come from the government agencies, they work better. Isn't that true, ma'am? When apps developed by private institutions or individual organizations, I don't know how far the reach of that app is going to be. Ma'am, the mic.
It has to sustain. Government is paying the charge for it, and you have huge space, and you don't have to pay the rent for it.
Yes, I mean this is
otherwise you have to pay the.
This is coming from personal experience also. You have numerous apps made for smaller things, and the sustainability of these apps and made by even a very passionate group makes an app is very difficult to sustain it. I think the app making or the portal handling has to be either linked to the government portal which is already there, or have a new portal made only for Cleft, but has to be involved with, the government has to be involved. And that brings me to the next point, that involvement of policymakers, government agencies at this point has become very crucial. I think that's the next step. And then we have Anup sir here, Ritu ma'am here, Seema ma'am here. I think you can all guide us to how we can rope in the government into looking at Cleft. And one great point that you raised, ma'am, that the patients themselves will have to be roped in to do that. And RBSK, I think all those who are from outside of Delhi, I think please approach your state officer of RBSK and see what can be done. I think that's a take-home message for those who are outside of Delhi. Thank you for offering e-Dant portal services, ma'am.
The
E smaller.
E smaller.
Yeah. D-E-N-T.
I shall do that and then project this again.
Well done.
E smaller.
E then Seva.
D-E-N-T.
S-E-E-N-T. Okay. E then Seva.
S-E-W.
S-E-W. So that's E then Dant Seva.
E then Seva.
E Dant Seva body. Thank you for offering that, and we'll see how we can take that.
Is there a hyphen
E is
there?
also small.
No, yes, there is a hyphen. So it is not a portal, it is just a site.
It's a site.
It's a website.
National Oral Health Program.
National Oral Health.
I think there should be D-A-N-T or
NOHP,
D-E-N-T.
under the NOHP program.
I think we'll put it on the minutes of the meeting.
Right, either Seva, that page will be.
Yeah. No, we'll put it on the minutes of the meeting. So this was already added. So I think we'll put it on the minutes of meeting. Everybody can access that because the minutes is going to be circulated.
But
so
I need to take a permission.
Yes,
And
no,
it is
yes.
just an
Offering.
don't minute it the way that she has agreed.
No,
I
yes,
put up the proposal.
Don't go ahead with the
Obviously, you will have to go.
No, ma'am is getting the permission. That would be
I would take this forward, but not that it is done.
It's not months.
It takes
Ma'am,
time.
it is till this time it was in my domain. Now after that you will have to take it.
Regarding this, you don't worry.
Yes. So we also talked about patient-related outcomes. Dr. Puneet did talk about this parent association, and I think this is crucial in reaching the government agencies, like ma'am said. Valuable input of making the registration compulsory. That's going to be tough. That's really going to be tough. I don't know how we're going to do that, but it should go in as a recommendation. Is there anything else the panel would like me to add?
There could be issues of patient with Aadhaar, I'm sure there's ways of overcoming it. Patient privacy, confidential. There might be some issues.
Just to get to the similar kind of a history, which is the Rare Disease portal, which is managed by Indian Council of Medical Research. They have made, the Supreme Court gave a ruling that it's not compulsory that a patient should share the Aadhaar. So they have made 3 mandatory fields. Like one is Aadhaar, if you want to enter, or you enter a ration card, or you enter a passport ID or a voter ID. And you also have to enter 2 more things, all the 3 to match. But the only problem we faced here was siblings, because everything matched, and we had 2 families, so we had to somehow escape that by using some other Aadhaar. But for Aadhaar to be made mandatory, the Supreme Court has already given a ruling. You can't make patient sharing with a social security number like Aadhaar, a mandatory service. So we have to use a couple of, so we used the mobile number, the voter ID and the Aadhaar card to make sure that duplications did not happen, and that was very much encrypted at the site of entry so that the data mining is compliant with all the cyber rules. So having a portal which has to be compliant with all the cyber rules is very, very important.
Dr. Seema, just one question. The rare disease, you said that registry, the patient registers, they get almost to the tune of 50 lakhs. So who pays them? Is the government? For every
for these patients. So you would be surprised the first amount of fund has already been sanctioned. So it's a big step the government has taken to create the policy. And when we actually went through it, we never thought it would materialize. I mean, how will the government be able to afford this much?
Wouldn't the number be closer as well when we include so many rare diseases?
Yeah, so these are rare diseases which have a definitive outcome and are within the ambit of 3 lakhs. They are not, this is a one-time grant. You can't have a renewal every year. So there has to be some way of sustaining. So all the patients like ID with small inborn metabolic errors. So these patients require about 4,000 to 5,000 a month. So they can sustain their entire life with this one.
Is there anything else the panel would like me to add to this?
A model to outreach the management services at the site of birth. A model where the management services can somehow go to the place where the
like what he said, linking the NGOs or any other organization providing cleft care.
Extend the support at the time of the place where the baby is there.
The whole system is being fragmented. If you all group together, it will be a beautiful pathway. She identifies, and then someone else from our side goes and picks up the patient, delivers the care, and we follow them up till 18 years, and then we give them the report of what's happened, because that can then sustain the government, that can go back to the feed to the government, and they can keep us the funding. I don't know how much of help it will be just to identify, but if you can show the government that your identification is crucial for that patient to get care for the next 18 years, that will definitely tip the government to keep that running.
Does that point, linking the cleft care services to the identification centers to develop a model? We'll reword it better, this is right from the top of my head right now.
I think you should tremendous. I think this is important. I think this is crucial because there is a mismatch at the moment, if I understand. So you identify, you don't know what to do with them.
What is the definition of center here?
Yeah, research points out that 20% of these patients don't get any care.
Yes.
Madam, I can speak for cleft and craniofacial.
Yeah, so if you say a center means are you giving a comprehensive treatment in all the aspects which is cleft care child needs, starting from all the team members? A center may be identified like a plastic surgery center who is only taking care of
When we say comprehensive cleft care, we have established centers, but not many of them are.
How many are there in India?
Can I answer that question? For instance, center where I work, we have practically everybody, including a clinical psychologist, nutritionist, feeding nurse, pediatric dentist, everybody who is needed, and every single service is delivered free of cost. Patient doesn't have, we also support some amount of patient travel.
Fair enough. So centers.
So there are several centers.
And individual clinics who are under SMILE training and not giving a comprehensive.
I think it's a difficult question to answer because you might find a center in a really rural area where there is nothing else, just the surgery. At least the patient can go there. You can't just have comprehensive, but it is a difficult one to answer.
No, then I can answer this.
You will have questions like this from the ministry. That what do you say as a center? So for me, even if I'm an orthodontist, my clinic is enrolled under SMILE training, and I am a orthodontist who is giving us under SMILE train a cleft care as an orthodontist. So individual clinic mapping, they have to be clubbed, like a plastic surgeon, an orthodontist, a speech therapist, they have to make a team. Then only you will say that this is the team of that state or near me. If I am, or in a radius of this many kilometers, that completes a center. How do you identify? And SMILE has left. So I just wanted to know how do you?
No, I can answer that question.
These centers are existent already, and we're not asking to refer to orthodontist of the SMILE.
Can I answer? I mean, she asked a very, very precise question.
Because when you are linking NGOs into it, you are asking somebody to direct. So there has to be a team which has to work for.
I got your question. You need to, like you said, there are a handful of centers who offer everything.
Yes.
There are several who offer partial.
Yes.
The quality also varies. So you need to give in the website what all facilities this particular center offers, free of cost.
Actually, then it will be very, very difficult.
No, you just have to give the link to the center.
Many a times patient doesn't want to go to a centralized center because that center is far off. Why patients drop into our center is because there's a lot of mountain population here, and because of these consanguineous marriages, we have pretty decent number of cleft patients. So these patients, many times I say, why don't you go to the SMILE Train Center because the treatment is free there. They say this center is near to my house. So ma'am, I think if the mapping has to be done, it has to be done for comprehensive centralized centers and for the decentralized services also.
That's a completely different. I can understand what you're coming from. It depends on the quality. It depends on the number of the workforce. It depends on how many surgeons they do in a year. If a comprehensive care center does only 5 surgeries in a year, they're not good enough. So it's going to be very difficult to that is unique for India. That is why we established the CCIS. What are the outcomes that they are getting as a comprehensive center in terms of 5 years, 12 years, and 20 years? If we can establish, let us say, 100 centers in India who produce good quality work, then we can feed the data to you. You can then put the data on the website and say these are the centers that they can be referred for quality. But we are nowhere near that because India is too far away from it.
Yes, I think the whole idea of centers, once you say mapping of these centers, right now maybe the government center, government organizations, and if we are looking at
only
the funding.
6%.
So, yes, so if you, I can suggest that how government thinks, right? So maybe that is the next question which comes to this forum. Like a Smile Train who is offering the financial support within a radius, they have to identify and make a comprehensive center. Like he's having a plastic surgery center, he's having an orthodontic center.
Actually,
so then
some
how
of them,
do we resolve this issue?
So
We
need,
cannot map
each
each and every individual clinic.
No. You need one center with a coordinator who, for instance, we have a coordinator. The clinician says this patient needs to be followed up at this point in time. So this person communicates with the patients. So if you have the coordinator's details, they will be able to guide them where to go and when to go.
How many coordinators are there? That's what I want to
Every center has a coordinator.
So
every conference
if my clinic is mapped with Smile Train, I am a coordinator, so I would choose my plastic surgeon.
Very much, yes.
We can continue these discussions over lunch. We are heading to lunch. We thank everyone for a wonderful time. It's been a great time of deliberation and discussion. I thank the panel for their inputs. But there is a lot of discussion going on, but due to paucity of time, we'll have to connect to this. I take this time to heartily thank every person who's made time to come here, contributed intelligently, and we want to continue to collaborate on this. We're going to bother you. This is not done here. We're going to be behind you, and we're going to take this further. Thank you, everyone.